and honored guests. Cardiovascular disease remain a major health burden worldwide and across Asia. As a top modifiable risk factor, hypertension presents unique clinical patterns and management challenges in special populations, especially women and young to middle-aged adults. There is an urgent need for standardized, regulated, and globally aligned clinical care pathways. For the advanced academic collaboration in cardiovascular medicine across Asia, improved prevention and management of hypertension in special population, and strengthen exchanges between Chinese and international experts. We are pleased to kick off the 2026 Asian Cardiovascular Disease series of web seminars co-hosted by the Asian Heart Society and the Beijing Society of Cardiology. Our theme today is dialogue between Chinese and foreign experts, standardized management and advanced progress of hypertension in special populations. We have arranged two keynote sessions featuring top-tier experts in the field. The first session focuses on the physiological characteristics and individualized management of hypertension in women, addressing real-world clinical challenges and practical guideline implementation. The second session covers evolving trends of hypertension in young and middle-aged populations, risk factor control, and long-term prognostic management with insights from cutting-edge research and daily clinical practice. Now, please allow me to introduce our distinguished speaker. The first speaker is Professor Jana Brguljan, a faculty of medicine from University of Ljubljana. She head Department of Hypertension, University Medical Center, Ljubljana, Slovenia, Professor of Internal Medicine, Faculty of Medicine, Head of Skills Center, Faculty of Medicine, University of Ljubljana. She's also key expertise hypertension, cardiovascular medicine, women's cardiovascular health, European hypertension specialist fellow of the ESC, council member, European Society of Hypertension, executive editor, Journal of Hypertension, president-elect, ESH Working Group on Hypertension in Women, past president, Slovene Society of Hypertension, selected publications, co-author 2023 ESH guidelines for the management of arterial hypertension. Also authored in Journal of Hypertension, European Heart Journal, Blood Pressure, and others. The second speaker is Professor Wang Hong from Tongji Hospital, Tongji Medical College, Huazhong University of Science and Technology. She is the chief physician, master's supervisor, director of echocardiography laboratory, U.S. National Institute of Health, postdoctoral fellow and visiting scholar at Cedars-Sinai Medical Center, awarded the postdoctoral fellowship by the American Heart Association, Cardiomyopathy Group, Society of Cardiology, Chinese Medical Association, Cardiac Critical Care Committee, Chinese Medical Doctor Association, Heart Failure Group, Cardiovascular Branch, Wuhan Medical Association, member of the Collateral Disease Branch of Wuhan Association, of traditional Chinese medicine and other academic scientists. Journal of Internal Intensive Medicine editorial board, President presided over and participated in NSFC, HBNSF, and other research projects, published over 30 SCI papers as first and corresponding author. Engaged in clinical diagnosis, treatment of cardiovascular disease, and echocardiographic imaging, with in-depth research on heart failure, myocarditis, cardiomyopathy, structural heart disease, and intraoperative echocardiographic monitoring. And there are two guests, Professor Luo Qin from Xinjiang Uyghur Autonomous Region People's Hospital. She is a medical doctor, chief physician, associate professor, doctoral supervisor, director, and academic leader, hypertension diagnosis and treatment center, Xinjiang Uyghur Autonomous Region People's Hospital, chairperson, the third Hypertension Special Committee, Xinjiang Medical Association, council member, Chinese Hypertension League, member, academic committee, NHC Key Laboratory of Hypertension Diagnosis and Treatment Research, editorial board member, Chinese Journal of General Practitioner, and Chinese Journal of Hypertension, member Hypertension Branch, Chinese Geriatrics Society, member the 7th Internal Medicine Committee, Xinjiang Medical Association. The second guest is Professor Wang Hui from the 8th Affiliated Hospital of Sunxian University, secondary level professor and first level chief physician at Sunxian University, chief scientist of a major national science and technology project, vice president and discipline leader of the 8th Affiliated Hospital, Sunxian University, founding director of the Guangdong, Hong Kong, Macau University Joint Laboratory for Prevention, Nutrition, Metabolism, and Chronic Disease Council, founding director of the Shenzhen Key Laboratory of Precision Prevention and Control for Major Chronic Disease and Metabolic Research. So we hope tonight's discussion will build consensus, inspire new thinking, and jointly advance cardiovascular disease prevention across the region. With that, I'm pleased to officially open today's webinar. Let's welcome the first speaker from Faculty of Medicine, University of Ljubljana, Professor Jana Brguljan. Her topic is women. Are we different in hypertension treatment? Please, Professor Ljubljana.
Thank you very much, Professor Wei, for this very kind introduction. And it's my great pleasure to be today with you, because I think it's very important to have this kind of relationship and try to exchange also what we feel, what we work, and how we can proceed. And I think that's why it's very important. Like you already mentioned, I work a lot at European Society of Hypertension, and also on their behalf, I would like to welcome you. And I try to explain my topic as much as possible so that you can also get some, let's say, experiences, or you can try to get some nice thoughts for the next days when you will be treating women in hypertension. So I try to dedicate, let's say, whole of my life to hypertension by itself. And now these days we try to work more on women on hypertension. And I will try to show you more why it's important that we think about treating hypertension in women. I will try now to share my slides and I hope you see it. Is everything fine?
Yes.
You see my slides? Okay. So already with these two photos, I tried to show why women are different. And definitely, of course, I would like to show you a little bit also about the country where I live. And I have to say that we live in a small country with only 2 million of population, but we have very nice things which you are always here for and welcome for you to come and visit us. And as you can see, this is one of our famous underground cave, which is very nice to see, to visit, and it's one of world heritage, which is very nice and important to see. We are also very famous in ski jumping, and we have a world record in ski jumping. And this is our ski jumper, which is very popular, and all of his family is very nice and popular. And then we have a lot of nice wine regions, culinary experiences. And now, maybe at last time, you've heard something about Jana Brguljan, and she's a climber. And I think for the moment, she's also having a tour in one of your countries. And with this, I would like to say that when we think about hypertension in women, we have to see that there are also sex differences in blood pressure, and they are apparent through all over the life course. As you can see, in younger ages, women have lower blood pressure, systolic and diastolic, but then in ages around above 65, the systolic blood pressure of women is rising and it's somewhat lower in comparison to men. This is the average age, life age, which we have in our country. As you can see, for 54 years, and then in 2023, of course, it rised a lot. So now it's the average 78.8. And on the other hand, you can see that the main cause of specific mortality in women is the biggest killer is also cardiovascular disease, the same as Professor Wei mentioned for all the other countries around the world. And this is why I think it's important that we try to think about hypertension, which is one of the most modifiable factors which we can modify if we try to treat it on time and if we treat really it on time. And if we think about women, we can say that probably we have three different periods in our life or in their life. So it's a period before pregnancy, then it's a period during the pregnancy, and then it's a period after the pregnancy. Even though we know that a lot of women are also not getting pregnant, but still the life cycle of the women is going through the childhood, then to early reproductive age, late reproductive, and then menopause. So even though women are not having children, are not delivering the children, the woman's, let's say, lifespan is like I'm projecting here, so coming from childhood and then coming to the menopause. And this is why we have also different causes or different, let's say, influences how and why hypertension in this, let's say, lifespans is or can be seen or can be detected. And definitely, essential hypertension presents itself differently in men and women. Before the menopause, of course, there are obvious hormonal differences between the sexes, and we also know that there are things after the menopause, and the most important thing is that the arterial tree ages differently. Then we all know that women are in shorter stature in women, and it's obligatory with that goes shorter arterial tree, which induces faster heart rate and earlier reflected arterial pathways. So all these factors operate to influence systolic blood pressure, pulse amplification, diastolic time in diastolic blood pressure. So the circulatory effects of these variables in young and within aging help to explain the time-dependent and aging differences in cardiovascular between men and women. There are several pathophysiological backgrounds of the sex-related differences in hypertension, and they are all based on, let's say, differences in cell sensitivity, differences in RAS system, arterial wall rigidity after the menopause, and like I already said, shorter arterial tree. That all goes together with vasorelaxation, sympathico inhibition, renal protection, and prevention of vascular modeling. So if we try now to think about the period before the pregnancy, we can see that in many cases, hypertension could be connected with the use of contraceptive agents. Then we have polycystic ovarian syndrome and endometriosis, which could be connected with hypertension. Then we have hypertension and assisted reproductive technologies. And of course, there is much higher possibility of secondary causes like fibromuscular dysplasia. And recently, there is a rise in invasive assisted reproduction technology, probably because of the way of the life. Women, we have a lot of problems now getting pregnant, and that's why we can try to see if there is a connection between assisted reproduction technology. And it looks like that there is increasing risk of preeclampsia, which is connected with its invasive assisted reproduction. And then in another meta-analysis where there were 85 longitudinal studies included with 8 million pregnancies, the main findings were the same with previous, but with a higher number of studies included. And frozen embryo transfers were associated also with higher rate of interpregnancy relationship and compared to the fresh embryo transfer, so even a little bit worse. Why is this connected? It's really hard to say, but probably there are different, let's say, mechanisms which are connecting these assisted reproductive technologies with the risk of hypertension and of course also with disorders of pregnancy. And we can never say with this, let's say, specific lady what is there in advantage, but we have to think about all these possibilities which can come out at a specific lady. Then we were talking about oral contraceptive pills and hypertension. And we are all aware that oral contraceptive pills are the one who can really rise blood pressure. And in summary, we can say estrogens and progestin used in oral contraceptive pills can cause hypertension, and natural estrogens at lower doses of synthetic estrogens are associated with lower blood pressure elevation. And dispropanolone has lower blood pressure and maybe even a lower effect. So it depends what is the difference and the ingredients of the oral contraceptive pill, what is the influence on the blood pressure. And you can see that this influence is changing. It depends on what is the level of estrogens and what is the level of progesterone in the contraceptive pill. And this is why we try to find the contraceptive pills with the lower influence on the blood pressure. But the truth is, if the lady is taking oral contraceptive pills and she's getting hypertension, we need to ask her to stop oral contraceptive pills and then see what will happen with hypertension. But on the other hand, we have to know if we stop contraceptive pills, then we have to ask them to use the different protection, because otherwise they will have different problems. So maybe they will not have hypertension, but then they have other problems, and we have to try to avoid these problems. What about during the pregnancy? This is really the period which are not comparable to men. And we have to say this is highly extreme biological process that marks a monumental transition in woman's life. This period involves a cascade of unparalleled endocrine changes, which is also going with numerous adaptations in woman's body. And in one of the investigations which were published in Nature Communications, that you can see, there was seen that there is, with magnetic resonance, seen changes in this brain of the pregnant woman. And the mapping of the resting state brain, you can see that it really must be something. That's why when we are pregnant, we are really something different, and we think in a different way, we act in a different way. So we have to be excused from time to time if we say something strong or if we act something strong, different. And then it's another thing about problems in pregnancy. Here you can see that ladies who are getting pregnant are not now getting older and older. And this is why we also are having more and more problems with hypertension during the pregnancy. And if we think about hypertensive disorders in pregnancy, first of all, we have to exclude that there is a possibility of wild-caught hypertension. We have to exclude possible mask hypertension. And then we have to think if there is a prolongation of chronic hypertension, which could be, of course, primary and secondary, or if we are talking about gestational hypertension, which will appear after the 20th week of pregnancy. And then, of course, we have to think how we are going to act and what we are going to do. So when we are having a lady and she's having hypertension during the pregnancy, we have to decide whether this is pre-existing chronic hypertension, whether this is gestational hypertension, and if maybe she's going towards the preeclampsia, and we have to think how to stop this pregnancy. And then, of course, we have pre-existing hypertension plus superimposed preeclampsia, and then is also part of unclassified hypertension. But when we think about the continuation of hypertension during the pregnancy, we have to ask always ourselves, is just the simple pre-existing hypertension, or there is maybe some iatrogenic cause of drugs, maybe, or maybe there is also pain which is causing hypertension, or only anxiety. That's why it is important that we consider possible secondary hypertension, and this we have to think if maternal age is lower than 35, if it's severe hypertension, and the possible etiology, of course, could be chronic kidney disease, primary hyperaldosteronism, renovascular hypertension, pheochromocytoma, Cushing syndrome, and obstructive sleep disease. These are all possibilities which we have to think if we are having a person with hypertension during the pregnancy. But on the other hand, we have to think that preeclampsia is the stage which can be caused, on one hand, described like before from maternal side, and on the other hand, it could be also from the baby side. So it's placental pathophysiology, and if it could be one or the other who could be causing the problems, and in this way we get like endothelial dysfunction, pro-inflammation, pro-coagulation, and this all then causes preeclampsia, which is then a problem for the baby and for, of course, the lady. And which antihypertensive treatment is better for mild or to moderate hypertension in pregnancy was always a question. It was also a question, should we treat this hypertension or not, or should we just wait? Because pregnancy is a very short period, and should we just start somewhat later? And this is why diagnosis of pregnancy was always be above 140/90, and mild to moderate hypertension we need 140 to 160 over 90 to 95, severe above 160. But the problem is that we have to define if it's really we have a possibility with ABPM, and those machines should be stratified or should be dedicated for pregnant women. And in this web page, Stride DBP, you can see which machines are suitable for the pregnancy. But talking about the treatment, we always said, okay, above 160, we need to treat. But what about below 160? And based on the results on CHIP and CHEP trials, now we really think that we should go and start treating already at 140/90, because the antihypertensives are now, the CHEP trial was the one where we could really see that it's important that we start treatment also in this mild hypertensive. And then this was the truth, and this was a change which really caused us to start thinking about medication and start thinking to treat antihypertensive with antihypertensive drugs during the pregnancy. But antihypertensive drug choice in pregnancy really remains largely determined by local practice rather than a strong evidence base. And if we look to management of hypertension at ESH, we would definitely first, our choice would be beta blocker labetalol or alpha methyldopa, and then we go also to nifedipine, and we have to know that AC inhibitors, ARBs, or diet renin inhibitors are not recommended during the pregnancy because they can cause malformation of fetus. That's why we have to avoid them. So the first line treatment, also in the American Heart Association, is labetalol, methyldopa, and nifedipine. And like we said, this is all based on the studies in the past. But nowadays, the truth is that beside labetalol, we are also using other beta blockers, and we don't see any large side effects, or we don't see any malformation of our fetus. And then, of course, for resistant hypertension, we go for nicardipine, clonidine, or furosemide. And also, if it's cell-sensitive chronic hypertension, we go for diuretics, but we have to be careful and always monitor baby and a lady. And this, if you take a look to this case of the lady, 38 years old, she came to our outpatient clinic. And as you can see, nothing special in family history. Her father had aneurysm of the aortic of ascending aortic. And then in present history, she was having high blood pressure at home, 150/95. Heart rate, it's important that you always also see what is the heart rate, was 95, and she wanted to get pregnant again. And this is why we were thinking how to proceed. As you can see, she was overweight, her height was, her body mass index was 37, and so on. Otherwise, everything, all the blood tests and ECG was normal, no microalbuminuria. And this is why we decided to stop methyldopa and ask her to take bisoprolol 5 milligrams, because she was not yet pregnant. She wanted to get pregnant. We didn't know how long that will go on. And you can see with this bisoprolol, her blood pressure was nicely controlled through all 24 hours. But then, and this is also one of the studies which showed that bisoprolol was safe during the pregnancy, and that's why we were also encouraged to use it. Another thing is aspirin during the treatment, and we know that the ladies who are in the higher risk of preeclampsia should take the aspirin, and we should think about taking aspirin in these ladies. What about the immediate postpartum period and then later in the life? We can say that later in the life, women are getting closer to men, closer to, let's say, the risk of cardiovascular events. But the truth is, if they had preeclampsia during the pregnancy, their risk is much higher. That's why we have to think when the ladies are coming to our office to ask them of possible preeclampsia during the pregnancy. And we have to know whether they were in that period. And then if they had, they are in a higher risk, as you can see, also for all the cardiac diseases. but many times we forget to ask them. But then when we are treating ladies in this postpartum period and then later in the life, we can see that the treatment could be similar to men. The truth is that the beta blockers are approximately the same used in men and women. We use a bit less of calcium channel blockers in women because they are more prone to peripheral edema. We use a little less ACE inhibitors, and we use also less diuretics. But on the average, we can see that during this period, usually women are treated in the same way as men. But the problem usually is that we are really treating less women than men. So if I try to conclude and not be too long, I think the most useful information for you would be how to approach to a lady in her fertile period. First of all, we have to know what are the correct measurement of blood pressure. So if possible, ambulatory blood pressure monitoring. We have to proceed with laboratory tests. We have to go for hypertension-mediated organ damage assessment, which you can see also on the right side. And we have to go through all this procedure to exclude the secondary possible cause of hypertension. And then we have to start treatment above 140/90. For the moment, guidelines are the same for both sexes because we do not have enough evidences to start treatment in women in lower blood pressure levels. And I hope in the future we will have more evidences and we will be able to, let's say, also to distinguish maybe better treatment in men in women. But till then, we'll try to go in the same direction. But we need to be to think about that women now are undertreated and that we have to think about better treatment of women. And with this, I would like to say and stress again that we shouldn't include RAS inhibitors in fertile period if lady will be pregnant in a short period, that we should use beta blockers, calcium channel antagonists, maybe methyl dopa, and we always need to have individual decision how are we going to treat this kind of ladies. And with this, I would like to thank you for your attention, and I'm available for your questions. And the truth is that men are always having some kind of, let's say, always say, oh, we are pregnant. But the truth, on the other hand, is that really most of the things are still on women's side. Thank you very much for your attention.
Professor Jana Brguljan, thank you very much for your very important and interesting speech. We'll talk about this topic at the panel discussion.
Okay, thank you.
Let's welcome the second speaker, Professor Wang Hong from Tongji Hospital, Tongji Medical College, Huazhong University of Science and Technology. His topic is the research progress in hypertension management among young and middle-aged adults. Welcome, Professor Wang Hong.
Can you see my screen?
Yes.
It's okay for my, okay.
Yes.
Okay, thank you very much for Professor Mao's introduction. It's also my great pleasure and honor to be here to talk about the hypertension topic. Dr. Jana just gave us a very great topic regarding a special situation of hypertension. It's hypertension in women. Now let's turn to another special situation, is hypertension among young and middle-aged adults. I will talk about the current status about this in China. Let's start from the epidemiological status of hypertension among middle-aged and young adults in China. We know hypertension now has been one of major public health in China, along with diabetes and lipid disorders and obesity. And let's look at this slide on the left side. We know the life expectancy in China has markedly increased. And the left part is early data from 1958 to 2012. We see the Chinese life expectancy increased from about 57 to 76. And along with this improvement in life expectancy, we see the prevalence rate of hypertension also increased a lot from around 5% to above 23%. And this is data, early data. Let's see the middle. The middle is a survey from the 3 different survey, and the latest survey is from 2021 to 2022. And this we see compared with the, particularly with the older elderly age group, we can see the increase. We can see the increased rate of prevalence hypertension in the middle-aged and young hypertension. In middle-aged and young age group, the incidence, the prevalence of hypertension increased faster than any other age group. Particularly, we see the green line, which is a survey from 2021 to 2022. The increase rate of hypertension prevalence is particularly fast, and also the increase rate is also true if we see the different grade of hypertension, no matter grade 1, grade 2, or grade 3. Although the trend is probably more upwards in grade 1 hypertension. The prevalence of hypertension in young and middle-aged people in China is not very optimistic. We can see still in the left side. The data is also early from 2012 to 2015. We can see the overall prevalence of hypertension is 22.1%. We have to see this data is early, 10 years from now, 10 years early from now, and I believe the data probably is much worse than this. And if we see the prevalence based on different type of hypertension, like control hypertension, isolated diastolic hypertension, or isolated systolic hypertension, or both systolic and diastolic hypertension, we also can see pay more attention in the young and the middle-aged group from like 18 to the 54 in the middle part of the graph. We can see in this age group, the controlled hypertension is worse than the other age group, and isolated diastolic hypertension is more obvious than other age group. And isolated systolic hypertension, which is common in elderly, however, in this graph we can see it's also not rare in the young and middle age group. All the things we see is not very optimistic in China. And here is the current state of hypertension control among middle and aged young adults. When we talk about hypertension, we often see three reads: awareness rate, treatment rate, control rate. We know the overall the 3 reads is much worse in China compared with European or US. However, we see the left side, the 3 reads in both in China and the US is comparable. We see there is a shared global challenge in the management of hypertension in this age group. And in the right side, in China's 3 rates, we can see the 3 rates in this young and middle-aged age group is worse than the elderly. Again, if we pay attention to the available rate of isolated diastolic hypertension, we can see in this kind of subtype hypertension, the available rate is even worse compared with other such as ISH or SDH. It means for this type of hypertension, isolated diastolic hypertension, we probably did not pay enough attention to it. And also, other than age, in people without previous cardiovascular disease or previous disease such as diabetes, the value rate is also low, is also very low. So the diagnosed rate of hypertension among this age group is suboptimal, and the factors may attribute to such as no enough screening for hypertension, no enough education for patient. If the patient did not measure their blood pressure, they get no opportunity to see the doctor to get diagnosed. The hypertension type also influence the diagnosed rate of hypertension. Again, the same as before I just talked. The isolated diastolic hypertension is the least hypertension type, which has the least diagnostic rate. Here is a retrospective cohort study, which showed the important factors contribute to the insufficient diagnosed rate of hypertension among this age group. They indicate in other than age, the type of blood pressure measurement, particularly diastolic blood pressure, in compared with systolic diastolic hypertension. The isolated diastolic blood hypertension is the least diagnosed. Again, show the different subtype hypertension may contribute to the diagnosed rate, different diagnosed rate. From different perspective, from patient's perspective and from doctor's perspective, the factors may have different factors to affect the diagnosed rate. From the patient perspective, such as mask hypertension, which is common in young and middle-aged patients, which may reduce the diagnostic rate of hypertension. And also young patients usually compared with elderly, they are often to neglect different their health management and pay not enough attention to the harm of hypertension, and have excessive worry about adverse reactions of medications, which makes it difficult to adhere to medication. And the worry about the adverse reactions is very common in Chinese people. From the doctor's perspective, some doctors in China, they think the ISH in young people is probably a form of fake hypertension. Usually, some Chinese doctors think ISH is common in elderly, but if it's in young people, they may consider it's a fake hypertension. This is one reason. Another some Chinese doctors think that diastolic blood pressure has lower impact on prognosis in systolic blood pressure. Therefore, isolated diastolic hypertension is often overlooked. This is another reason. Overall, let's see the clinical characteristics of hypertension in middle-aged and young adults. One is in this age group usually has sympathetic hyperactivation, which often present as rapid heart rate. And the second, the young adults, young hypertensive adults usually have no symptoms or have atypical symptoms. And most of them have mild hypertension, such as grade 1 hypertension is much common in young adults. And elevated diastolic blood pressure is the main feature, and some people just present as isolated diastolic hypertension. And this group of patients usually combine with obesity, overweight, and other metabolic abnormalities. And also the young people often neglect the home blood pressure monitor. This is also contributed to the low diagnostic rate in this age group. And the second, let's talk about something about the hypertension and CVD risk in middle-aged and young adults. Hypertension is one of the major cardiovascular risk factors. This is a common sense in most doctors. However, in young adults, in middle-aged and young hypertensive patients, the link between hypertension and the CVD risk is even stronger. Here is a data from Japan. Japan is a country which has the similar demographic characteristics in China. Let's see the left side. This is a retrospective cohort study. It's measure the grade 1 hypertension and the different subtype of hypertension, isolated IDH, ISH, and systolic and diastolic hypertension. We can see compared with elderly, the age group in 20 to 49 and 80 and 50 to 59 age groups had higher ASD CVD risk compared with elderly. The right side has the same result, just present differently. And another study from Korea, another Asian country, also showing the CVD risk associated with IDH is also higher in young hypertensive patients compared to elderly patients. Here, the cutoff criteria for the hypertension is 130 over 80. We can see for the in the 20 to 39 age group, the IDH has the higher risk compared with 40 to 64 and 65 to 89 age group. So it indicates we should pay more attention to the IDH in young hypertensive patients. Here the data is also, I think it's also from Korea. And here compare the CVD risk between grade 1 and grade 2 hypertension and different subtype of hypertension. We can see even compared with normal blood pressure or high normal blood pressure patients, grade 1, grade 2, or different subtype of hypertension also have higher cardiovascular risk. Of course, the level 2, grade 2 systolic and diastolic hypertension has the highest risk. However, even grade 1 or isolated diastolic hypertension also increase the risk of CVD. Let's go to the last part. Now we will talk about the treatment, how we choose, choose the management strategies in this age group. When we talk about treatment, we need to ask three important questions. The first is timing of blood pressure intervention. That means what is the best time to initiate our treatment. The second is the goals, is blood pressure lowering goals. What is the best goals? And the third, what is the principles of antihypertensive treatment? The most important is how.
没说让我打到屏上吧，就是我的问题啊什么的，我的讲的东西。这样，没说哦，就说。
That is how do we choose the best management strategies? Again, even grade 1 hypertension increase the risk of cardiovascular disease and mortality. Here we see the dark blue, the third bar, the dark blue bar, which is grade 1 hypertension. Compared with normal or normal high blood pressure, even grade 1 hypertension increase the cardiovascular disease risk and all-cause mortality greatly. That means probably we should start our treatment at grade 1 hypertension. And here is a study in China. Here is a prospective cohort study followed from 1992 to 2007. There are two major findings. One, we can see over about a 15-year period, follow-up period, about 65% of participants with grade 1 hypertension at baseline, aged 35 to 59, had their blood pressure increased to higher than 140 over 90 or higher at end of follow-up. And another finding is, let's see here, this line. For the patient at the baseline have the blood pressure higher than 130 and over 80. If we don't treat them until we find that blood pressure increase to over 140, over higher than 140 over 90, then we can see the total, the overall CVD risk at end of follow-up. That means 2007, that total, their cardiovascular risk increased by almost 3 times than the normal people. That means the people at baseline and at follow-up with the normal blood pressure. It also indicates we can wait until grade 2 hypertension to start treatment. Here is another prospective study that is interesting, that to start treatment until grade 2 at grade 2 hypertension. We see even we treat grade 2 hypertension to reduce blood pressure to normal blood pressure, compare with normal baseline normal blood pressure patients, their cardiovascular disease risk still higher. That indicates that the cumulative exposure to hypertension, if we wait until grade 2 hypertension to initiate treatment, it cannot fully restore the CVD risk to ideal level or restore to the baseline level. This also again emphasizes the necessity of early blood pressure management. Also, this is another study. They start treatment at grade 1 hypertension. We can see the when we start treatment at grade 1 hypertension, we can see the CVD risk can almost fully restored to the level close to 1. It's the same for for men and women. So based on the data we just talked about, again, also we focus on the recommendation from Chinese guideline. We have a Chinese expert consensus, I think it's published on 2020, on the management of hypertension in young and middle-aged patients. They see the timing. First, the timing of treatment at 2 points. If the patient has no cardiovascular or low cardiovascular risk, then we can start lifetime interventions for several weeks, and then if blood pressure remains uncontrolled, we then initiate pharmacological treatment. And the second, if the patient has hypertension and at higher cardiovascular risk, then we should initiate pharmacological treatment promptly. This recommendation, I think, is the same as in other age group. And they also give the drug selections. And in this consensus, they recommended beta blockers and RAS inhibitors. Both medications are particularly effective in patients with activated SNS in the RAS, especially for lowering diastolic blood pressure, which is very common in young adults. And the beta blockers is also suitable for patients with increased heart rate and patients with coronary artery disease and with heart failure. And also, RAS inhibitors are recommended for patients with metabolic disorders, with obesities, with diabetes, and others. And also, this consensus also give the other recommendation regarding the blood pressure targets and the principles of treatment. For uncontrolled young and middle-aged hypertensive patients, the target blood pressure target is the same as the other age group. The first target is 140/90, and if tolerated, it should be reduced to 130/80. And for patients with comorbidities, we should use 130/80 as the target blood pressure. And for principles of treatment, this consensus recommend to start intervention early and start both long pharmacological and pharmacological treatments. And other than control blood pressure, we should also comprehensively managing other reversible cardiovascular risk factors, which is very common in young people, such as obesity, dyslipidemia, and others. And the overall target is to minimize the occurrence of mortality risk of ASCVD. Regarding the long pharmacological treatment, we should pay attention to body weight control and limit sodium intake. And it suggests at least 6 grams salt per day, and some consensus or guidelines suggest even lower, like 5 grams salt per day. And also quit smoking and limit alcohol consumption, and increase aerobic exercise and reduce mental stress. Regarding beta blockers, there are some mechanisms to explain its role in hypertension treatment in this young and middle-aged group, such as slow heart rate and reduced cardiac output, which is very effective in control diastolic blood pressure, and they inhibit renin release and angiotensin II production, and reduce release of long freeing from sympathetic nerve terminals and decrease central vasoconstrictor activity, reduce venous return, and attenuate catecholamine release during exercise and stress. Here are some recommendations from current guidelines. The first is our Chinese 2024 guidelines for hypertension management. Our guideline still recommend beta blockers as one of the first-line antihypertensive drugs, and it recommend the beta blockers antihypertensive efficacy is relatively better in young and middle-aged patients, and it's also reserved for some special situations such as coronary heart disease, myocardial infarction, heart failure, and tachyarrhythmias, and increased sympathetic activity such as presented as the fast heart rate. In 2023 ESH guidelines, I know these guidelines did not recommend or did not involve beta blockers as the general treatment algorithm. However, beta blockers still are recommended or reserved for some special indication or situations, such as in young hypertensive women, which Dr. Jana just talked about. And other Chinese or other countries' guidelines in hypertension has the similar recommendations for beta blockers use. And the effect of beta blockers in reducing diastolic blood pressure is very efficient in compared with other kind of antihypertensive medications. We see the second bar, the beta blockers in the red bar, using the standard dose compared with others such as RAS inhibitors or CCB. In controlling diastolic blood pressure, beta blockers efficacy is the best. Compliance also influence blood pressure control greatly. So in our practice, daily practice, we also suggest to use long-lasting antihypertensive drugs and also the SPC to improve compliance to finally increase the blood pressure control rate. Current guidelines, including our Chinese hypertension guidelines, recommend initial combination therapy, and beta blockers plus CCB is one of recommended combination strategies recommended in our guidelines. And SPC is the current trend in antihypertensive treatment. Is very efficient for increased compliance and finally increased control rate of hypertension. And finally, I talk about the C plus B combination therapy. The right side is the flow chart for selecting monotherapy or combination therapy recommended by our Chinese 2024 guidelines. CCB plus beta blocker is one of combination strategies recommended by our guidelines. And in Chinese market, bisoprolol plus amlodipine is only available SPC, C plus B SPC in Chinese market. In summary, today we talk about the current epidemiological data and the clinical characteristics of hypertension in young and middle-aged group in China. We also talk about the association between hypertension and the CVD risk in this age group, and emphasize the importance of IDH. And finally, we talk about antihypertensive strategies for managing this age group patients with hypertension. Thank you very much for your attention.
Thank you very much, Professor Wang Hong, for your very clearly speech, for introduction for research progress in hypertension among young and middle-aged adults. Very important information about this topic. Thank you for your sharing. Next, let's go into panel discussion time. There are two discussion guests from Wang, Professor Luo Qin from Xinjiang, and Huang Hui, Professor Huang Hui from the 8th Affiliated Hospital of Sunxian University.
Good night, distinguished professors.
Professor Luo Qin, would you please give your opinion about tonight's two subjects?
Okay. It's my great honor to join this discussion. And good night, distinguished professors. We heard the two excellent presentations from two professors, and now I'd like to share my views on these three issues. For the first question, I want to highlight three major pain points. Pinpoint one, under recognition of sex-specific risk factors. As we know, the 2022 HE and ACC guideline has made progress by including reproductive history in the prevent risk calculator. But in routine practice, very few clinicians routinely ask about the history of gestational hypertension or preterm birth. So I think we should add this part of history of patients, hypertensive patients. And last year, a Mayo clinical review states that the current guideline does not provide specific recommendations related to the management of hypertension by sex. So I think this is a significant gap. And the pain point two, differential profiles and adherence by sex. Women consistently report higher risk of adverse reactions, particular ACE inhibitors and CCB, ADMA. This leads to higher discontinuation rates, yet most clinical trials do not stratify adverse events by sex. And a recent review found that while 81% of trials report sex, but less than 1% stratified adverse event by sex. So this is I think this is a critical evidence gap. For evidence-based optimization strategies, first, I agree with recent publication in the Chinese Journal of Hypertension proposed building an integrated life course-oriented framework for blood pressure management in women. The management that spans preconception counseling for women on RAS inhibitors, pregnancy as a window for risk stratification and postpartum follow-up should be a standard process in women, and menopause transition as a time for intensive surveillance. And stretch 2, I think from Professor Brguljan lectures, we can see screening for secondary hypertension in women is also very important, especially in young women. The proportion affected by secondary hypertension is higher, and primary aldosteronism is the most common cause, and FMD has a 9-fold higher prevalence in women. When using oral estrogen, plasma renin activity is more suitable than plasma renin concentration for case detection, because estrogen can cause false positive results with primary plasma renin concentration. Recent intervention study demonstrated that trailing existing evidence-based hypertension programs to include sex-specific cardiovascular risk factors such as pregnancy history and gender-related barriers can significantly improve the hypertension management in women. So in summary, for the first question, I think blood pressure targets are the same for men and women, but the pathway to achieve those targets is different. So we need life course thinking, systematic screening for secondary causes in women, and even we need multidisciplinary collaboration. And for the question 2,
去厕所，我在洗手间开会一下。
current evidence indicates that for patients with hypertension without comorbidities, beta blockers are not typically recommended as first-line therapy. However, for young and middle-aged hypertensive patients with a resting heart rate greater than 80 beats per minute, beta blockers can be prioritized. Additionally, for patients with coronary artery disease, chronic heart failure, and or rapid arrhythmias, beta blockers provide significant benefits and are strongly recommended. So the recommendation strength is therefore context dependent. For heart rate control in young patients without comorbidities, there is a moderate recommendation. For patients with concomitant cardiac conditions, there is a strong recommendation. And the factors affecting patients' acceptance and adherence, this is perhaps the most practical part of our discussion. What affects whether young patients will actually take their medications? I think the first one is side effective concerns. Young patients are often highly concerned about fatigue and reduced exercise tolerance, sexual function, and weight gain. And beta blockers can impact on metabolic parameters So these concerns directly affect the acceptance of beta blockers. And some additional young and middle-aged patients with hypertension often feel completely fine. So they have no symptoms in most of young and middle-aged patients. So the question becomes, they often think that why should I take a pill every day when I don't feel sick? So this is another barrier. And the third factor is understanding of heart rate for young and middle-aged hypertension with elevated heart rate. Adherence is the real challenge. The disease scale is substantial, but only about 20% adherence rate tell us that simple once daily regions with good tolerability are essential. So education about why resting heart rate matters is critical. For the third question, I think the beta blocker selection, bisoprolol, offers distinct advantages in selectivity and tolerability. It's a high selective beta 1 selectivity and once daily dosing and lower central nerve system side effect profile make it an excellent choice for young people, especially elevated heart rate, and also is a very excellent choice for female hypertensive patients during pregnancy. Especially when there is limited choice in pregnancy women, and also is excellent choice for hypertensive patients with COPD, and also is fit for patients who have not tolerated other beta blockers. In brief, hypertension management is not one size fits all. Understanding these population-specific considerations allows us to provide better and more personalized care. The above is my personal views. Thank you for your listening.
Thank you, Professor Luo Qin, for your wonderful speech. Professor Huang Hui,
Hi.
would you please give your suggestion?
Okay. Thank you, Professor Mao and Professor Zila, and I'm Hui Huang, come from the Guangdong province, Shenzhen, and also it is the youngest city in China, because the average of the whole city is about 32. So talking about the hypertension, I think I have some suggestion and or some question about this topic to share. And first of all, the current status of hypertension and in many cities in China, because most of the country or city, the people get older and older, so we can see the mobility of the hypertension is get increased. But it's very interesting to see in Shenzhen, it's a very young city. the I mean, the people suffer with hypertension is also very high. It's not because we found, and in the young people, I mean, the currency may be lower, but in Shenzhen it's very high and equal to the just like Shanghai, Beijing, or other aging cities or aging country. And I think this is a very important issue about social development and life expectancy in China, because most people in this city work very hard and maybe less sleep and more stress and about the diet and a lot of things involved and made the people suffer more chance of hypertension. And so the problem is we have a lot or a huge people suffer with hypertension in young or middle age. And talking about the prevalence of hypertension in young and middle-aged people in China, this is a very important issue because we can find some people just have a sudden death in young or in the middle age. Most of the reason is about the cardiovascular disease, and the most important risk factor is hypertension. And also we know the people with well-controlled blood pressure in China is not very good phenomenon, because people sometimes do not take the medicine or would not take the medicine for a long time. So that's made their blood pressure control will have some just like people cannot keep the blood pressure in the stable condition. Among the hypertension subtype in middle age and young adults, and the awareness rate of IDH is lower than the ISH and SDH. When we know the people get older, most of them will develop in ISH. ISH in the old people, and all the clinical doctor will focus on this. But when the young people suffer with hypertension, the patient will not take the medicine from a very young age. And also the doctor will thinking about maybe they have more chance to just adjust their lifestyle or diet and a lot of things we can maybe wait for him or for her to take the medicine. But we know when they exposed to the high blood pressure for a long time, that is a terrible thing for their organ, such as the kidney, vascular, and also the heart. And especially the young people will have more activity, and they just like they play or they run or they have a lot of walk. They walk day and night. There will be a big challenge to their cardiovascular system or circulating system. They also lead to a very high risk of cardiovascular event or MACE. The important factor contribute to the insufference diagnosis rate of hypertension among the mid-age and young adult is about they do not want to take the will not want to go to the hospital and take the medicine or try to fight their suffer with hypertension, because they want to have more chance for they develop in their career, and also they have to just take care of the whole family, about the young guy, about their children, and also their parents. So the burden of the middle age in China will is a very important issue they are considered about. And also for the doctor, on the other hand, for the doctor, they will they will think the young people maybe have a less chance to suffer with MACE, and then they will maybe not so positive about this. When we analysis of the important factors contribute to the diagnosis rate of hypertension among the young age, and about the doctors and the patients, and they will a lot of things just involved, such as the masked hypertension in young and middle-aged patients, and some patients are busy with work and will just forget about their health management, and the patient that do not have enough knowledge about their harm of hypertension. They're just thinking about maybe we have less risk of about that, and maybe they would not take the annual check about the blood pressure or cardiovascular evaluation. About the clinical characteristics of hypertension in middle age and young adults, I think we just talked about, and we learned a lot from the speaker. And we are very interested about the patients suffer with hypertension in the woman, because when they get pregnancy, and also the people have a lot of phenomenal change. So I want to I want to raise a question to discuss here, and as a normal, just no matter you are human or other animals get pregnancy, and the blood pressure in the body is get lower to make the baby or make the placenta have a more blood supply. And so I'm thinking about which level of hypertension we should control to maintain the less organ damage and also the good development of the baby, because IUGD means the intrauterine growth regression is not good if the mother or the baby with lower blood pressure during the pregnancy. So this is my question: which the target that we should control, and maybe for the 10 months, maybe in the early or middle or the late stage of the pregnancy, maybe the target is different. So I want to listen to some suggestion from the speaker and from the Professor Mao and others, and also about the cardiovascular disease risk associated with the IDH is higher in the young hypertensive patients compared with the elder patient. As we know, when people in the 20 to 40 age, I mean, this is the young and the middle age, they will have a very high chance of the IDH. And when people do not pay attention to them, they will develop to severe MACE. And in the young population, the comparison of cardiovascular disease risk between grade 1 ISH, grade 1 IDH, and the grade 2 hypertension, you can see maybe the people with the grade 1 IDH maybe have more chance to suffer with the MACE. And talking about the treatment, about the blood pressure control, there will be it's a big challenge. And just now, another professor talking about their suggestion. I think this is very important. Just like we need to lower the blood pressure, at the same time we lower the heart rate, and to reduce the cardiovascular disease risk. This is, I think, I completely agree with them. And another point is the timing of the job initiation and principle of the job selection, especially in the patient with pregnancy. It's sometimes maybe we cannot understand or cannot make a clear decision about for the patients, because sometimes the suggestion from HA and also from the just like the OB association, the suggestion may be completely different. In HA, I think they will suggest a lower pressure maybe have a more benefit for the future for the mother, and maybe in the OD association they suggest maybe just about 140 or 160 is okay for them to if the baby have enough blood supply and maybe their blood pressure is not have just like the blood just like the urine protein, that will be okay. So I just want to know when should we give the medicine to the patient. We just want to raise this question and hope have their suggestion in the clinical work. And also in most of the physicians, we just use the non pharmacology treatment, just like we control the body weight and also the lower the sodium intake and stop smoking and about the alcohol consumption and something like this. And most of the important treatment is the beta blocker is the major and very effective medicine for the young and the middle-aged patient. And this is all I should share. So in summary, I want to thank you, Professor Mao, to raise this very important conference. Then we have a chance to listen to most important opinion from the famous speaker and talk with other specialists about hypertension. And also, and I want to have your suggestion about just like the patient with pregnancy, which target we should control about the blood pressure, and when shall we give the medicine, and what kind of medicine is made the mother benefit from the most. Okay, that's what I want to share. Thank you, Professor Mao.
Thanks a lot to Professor Huang Hui for your very important viewpoints. Now, Professor Jana, may I have time put a question to you?
Yes, sure, please.
Thank you. We know female hypertension has a significant gender heterogeneity and full physiological cycle differences from male patients. Thus, standardized management of female hypertension is very important. But there are very few very important randomized clinical trial on women's hypertension management. So this situation results in lacking of strong evidence for prevention, treatment, and management for these patients, these kind of patients. What's your suggestion that we can make some changes about it?
Well, thank you, Professor Mao Wei. I mean, this is a very important point which you raised. And the truth is that in most of the studies, women were underrepresented. That's why we cannot talk about specific guidelines for men and for women. This is the problem, of course, it will stay like that. And it's also another point which Professor Hui has raised, that in the pregnancy, blood pressure is in physiological way going down. So what would be that blood pressure when we should start treating? So these are all the questions which are not really answered till now. So the best to our knowledge, what we can do is that we treat then women like men. And we start treating about 140/90, and we go low to 130/80. So we do not have any differences in gender, considering when to start and till which level we go with the blood pressure. But the point is, also in pregnancy with the CHAP and the SHIP trial, we could see that even if we start treating already about 140/90, that we get a desirable good effect. That's why we are now not afraid to start treatment anymore, even earlier. So that's the problem one. And on the other hand, of course, for the drugs, there are not so many studies done which drugs are safe, but definitely the most used one are methyl-dopa, and sometimes people are afraid that maybe depression will appear. But I have to say that for all my work during these last 30 years, I didn't see any depression with methyl-dopa, and it works well. And then we have nifedipine, so that's also one of the calcium channel blockers. And the truth is that we are also using other calcium channel blockers, even though they are not in the guidelines. So we also use amlodipine, but it works well. And then we have labetalol in the guidelines, one of the beta blockers, but we also use others. Like you see, there was a study with bisoprolol when it was safe to use, and probably also the other beta blockers should be fine, but we cannot put them in the guidelines because we do not have data. So for the moment, what I would say is that we go in the same way for the treatment than in men, but it's important, like it was already stressed, that in history taking, we ask about possibility of preeclampsia during the pregnancy, because this is very important to know. And in this way, we have to treat these ladies, these women, more closely. But for the moment, this is the only thing what we can do. And the truth is that response to beta blockers in women is good. But on the other hand, of course, we also have to think if these women are maybe in young ages, if they are athletes or there are other ladies working in sport, on training sport, then we have to be careful with beta blockers because they are not then really appropriate for those individuals. So we have to think individually and we apply treatment individually. But for the moment, in guidelines, there are no changes between men and women in certain period. That's it.
Thank you. Thank you very much, Professor Jana, for your very important perspective and very important suggestions for practice. Now we have come to the end of tonight's time. First of all, I'd like to extend my sincere thanks to Professor Jana Brguljan for sharing the latest international insights. I also want to thank Professor Wang Hong, Professor Luo Qin, and Professor Huang Hui, and all Chinese experts for their excellent presentations and in-depth discussions. Our speakers have covered key topics, including gender-specific management of hypertension, updated strategies for young and middle-aged patients, combining the latest guidelines with the real-world clinical practice. We've had a comprehensive, high-level, and insightful discussion. Many practical and clinically valuable viewpoints have been shared, offering clear directions for standardized hypertension care in special populations. I've personally gained a great deal for today's exchange. I fully agree that we should uphold the core principles about prevention, treatment, and management for hypertension, long term, even lifetime. Actually, what I want to express even more is this webinar has built a solid academic platform for China international exchange, advancing collaborative development in cardiovascular care across Asia. Once again, thank you to all speakers, participants, and Merck for your great support. Looking forward to seeing you again and next time. Thank you. Bye-bye.
Thank you to you. Congratulations for this great event, and thank you very much for your kind invitation. It was a great honor for me.
See you later, Professor
Bye.
Jana, Professor Luo Qin, Professor Huang Hui, and Professor Huang Hong. Thank you.
Bye
Good night.
bye,
Good
Professor
evening.
Mao Wei.